health service. Let's face it, let's be honest, we're deluding ourselves if we truly believe it is even now a truly national health service. Scotland and Wales run their own NHSs, and the English NHS contains such wide variations that it can't be said to be truly national. Treatments that are available in one area are not in another. Outcomes vary so widely that the use of the word national becomes laughable, if not redundant. So why don't we ditch the sentiment and recognise that the costs of running a national institution may sometimes outweigh any benefits that there are? The main benefit ought to be massive purchasing power that such an organisation enjoys. But we all know, at least I think we do, that NHS procurement procedures are almost as inefficient as those in the Ministry of Defence, and that's saying something. Suppliers and drugs companies appear to run rings around NHS purchasing managers and get away with imposing what is laughably called NHS inflation. So let's stop pretending about the single benefit of primary care trust was that they didn't pretend at all. They were proof positive that everything is local. And with a growing elderly population, how will we cope with mounting demands on geriatric care in hospitals and social care outside hospitals? The challenge for the government and indeed NHS planners is how to integrate the two. Otherwise, we have to try to find bureaucratic ways of achieving a separation of health from social care in terms of costs and resources. There are far too many geriatric patients who take up bed space in hospitals because there is nowhere else for them to go. Successive governments have failed to plan for the future. And although the coalition has announced a plan of action in this area, I wonder how many of us are convinced by it. And until politicians finally have the courage to tell people, yes, you'll have to sell your home to pay for social care, the debate will remain somewhat stagnant, but don't hold your breath on that one. The state cannot be able to meet every demand that is made of it in the area of social care, and people should not be misled into thinking that it ever will. Just look at the statistics. The number of people aged 90 or over has trebled in the last 30 years. The number of people who live to 100 has gone up fivefold. Over the next 25 years, the number of 80-year-olds will double. The number of centenarians will rise from 13,000 at the moment to 111,000. ONS projections say that increases in lifespans attributed to improving medicine, growing wealth, healthier lifestyles, and less physically demanding work will lead to a society where more than 1 in 5 people is a pensioner. Think about the consequences of that for what you do. To the government's credit, they are reforming the pension system to take into account these demographic changes, but where is the full planning in the health and social care systems? Now, very few people have anything nice to say about NICE, the National Institute for Care Excellence, and I'm probably going to be no exception. It was set up by the last Labour government with the best of intentions. Part of its mission was to end variation medical treatment across the country and ensure that if a drug was found to be effective, patients should not have to fight to get it. Now, clearly there needs to be a body which licenses drugs, but there is a huge suspicion that too many drugs are still licensed through budgetary consideration rather than clinical need. And in turn, drugs which are available in some parts of the country are not in others, for much the same reason. And if a cancer patient should have the temerity to decide to use their life savings to fund their treatment, using a drug for which budgetary reasons is not available via the NHS, what does the NHS do? Well, instead of saying thank you very much for helping us out and paying for your own drugs, it refuses then to continue any treatment for that patient. See? Public good, private bad. To me, that's the politics of envy, and basically says that just because everyone can't have it, you can't have it either. So people die. Now, is that really what should be happening in a modern-day healthcare system? I don't think so. It's the exemplification of the kind of dogma which has bedeviled that public sector thinking over many decades. This is what happened to one of my listeners who emailed me this last week. He said this: "My 23-year-old son has just been turned down for a course of drugs for his acute vasculitis, which he's been waiting around 5 months for. Costs around £4,000 for the course. His consultant has stated that it's one of the few drugs that would really make a difference He had to go back into hospital in the early hours of Tuesday morning, and they probably spent half that amount running more tests and keeping him in under observation, when he could have been back at work, earning a living, paying taxes, and with a reasonably pain-free outcome. How short-sighted can you be? Well, it's a good question, isn't it? And I'm surprised that no one has yet, and maybe you know different, but I've found no evidence that anybody has ever taken NICE or the NHS to the European Court of Human Rights over issues like that, but I suspect it's a matter of time. Perhaps then, the postcode lottery may forcibly be brought to an end. One thing I noticed when my mother spent those awful weeks in hospital was that the place more or less shut down at weekends, as do GP surgeries in large part. Well, how odd. I mean, aren't people supposed to get ill at weekends? Surely we should now be doing more to move towards a full 7-day NHS with a quality of service provision throughout those 7 days. If we're to get better outcomes, surely that has to happen over time. It comes back to the point I made earlier about 21st century medicine operating within the straitjacket of a 1940s system. Why is it that GP surgeries offer appointments at times a majority of people in the population aren't actually available to go to them? Why isn't there more evening and weekend opening? I run a publishing company as well as being a radio presenter, and I reckon I lose hundreds of man-hours of work a year because my employees say, I've got a doctor's appointment, as if that is a reason why they should be allowed time off to the detriment of the company. Now, I let them have the time off because I'd be a very bad employer if I didn't. But it may sound harsh what I've just said, but multiply that over the economy and we're all losing out because GPs have always worked that way, and some of them seem immune to the changes of a modern day economy. I don't blame them for negotiating the GP contract back in 2004, which allowed their pay to rocket for working fewer hours. Who wouldn't? But quite what the Health Secretary Alan Milburn was thinking of, God alone knows, and it's this government which has been left the legacy. And that legacy, at least in part, is A&E departments which are bursting at the seams with patients who shouldn't even be there. We now have the frankly ludicrous scenario of A&E departments employing GPs to see all the people who visit A&Es because they have no way of seeing their GPs at weekends, or at least that's their perception. These GPs are employed for one reason only, to allow A&Es to meet their waiting time targets. Now, the final area I want to cover this morning is one which is not an afterthought, but possibly is one of the most important challenges the NHS faces. Now, it's become almost a cliche to describe mental health as a Cinderella service. It's a subject too few people take seriously, and one that some still find difficult to discuss. While the stigma of mental health has been eroded, it is still there. When I started presenting my show on the radio 3.5 years ago, I never for one moment thought I would become known for my programmes on mental health, let alone be shortlisted for an award by the mental health charity Mind. But I can remember the heartbreaking calls I took when I first did a phone-in on depression. In fact, I could have devoted this whole speech to mental health and the problems associated with it, and after listening to me so far, you may wish I had. And perhaps this explains why the mental health covers a multitude of issues. And when you look at the statistics on mental health, you wonder why more resources aren't devoted to this area of health provision. I mean, look around this room. 1 in 4 people in this room will suffer from some sort of mental health condition, not just in their lifetimes, but this year. 1/4 won't visit their GP. But the real question is what happens if they do visit their GP? Now, anecdotal evidence from my listeners suggests that not enough GPs are equipped to deal with mental health issues. Maybe older GPs didn't have the same kind of training which is available today. I don't know. But time after time, people tell me that their GPs seem out of their depth on these type of issues. And perhaps this explains why the prescription of drugs seems to be the automatic default for so many GPs. But part of the problem is that people suffering from mental health problems or their families face a bewildering system which is so complex that even those who are familiar with it find it baffling. We have mental health trusts, but there are also acute trusts which provide liaison psychiatry services and some A&E services for mental health patients. Ambulance trusts may or may not be commissioned to provide mental health conveyancing services outside of emergencies. Clinical commissioning groups commission some services, while specialist trusts commission others. And then, of course, there are GPs who provide primary mental health care to some 83% of mental health patients. And then finally, you have local authorities who oversee and or directly employ approved mental health practitioners, or at least those who are not employed by or seconded to the NHS. Now, I can't believe to cover all the aspects of mental health here, and I'm not going to try, but I do want to touch on dementia care. This is where the NHS and the social care system need to interact far better than they do at the moment. No one seems to have got to grips with the demands that the increasing number of people suffering from dementia are placing on both systems, and that can only get worse. Everyone has good intentions, but so far it has to be said that not a lot has changed. The trouble is that to provide a proper care system for people with dementia will mean that huge amounts of extra money needs to be spent. But where is it going to come from? The usual question. Indeed, the mental health budget is experiencing a 2% cut. Beds continue to be closed, but we're constantly told that it is far better to treat people in their own homes. Well, really? The true heroes are those relatives who end up being carers for people with dementia. And what I believe we need to do, even as a short-term fix, is to provide far better support for them, especially more respite care. Because in effect, family carers are saving the NHS or the social care system hundreds of millions, if not several billion pounds each year. The Mental Health Action Plan, which Nick Clegg announced a week ago, was a welcome recognition that the current system isn't working, but it really was a list of aspirations rather than firm commitments. But things, I think, are starting to move in the right direction. It's great to see professional sports people be open about their mental health problems. It's great that some politicians have confronted their own issues surrounding their own mental health, even making speeches in the chamber of the House of Commons about it. It's great that programmes like mine discuss these issues openly and without hesitation. None of those things would have happened even 10 years ago. And if even just one person is helped by those discussions and they realise they're not alone, I feel I've done something worthwhile. So, in conclusion, let me give you some predictions. First, that all politicians will tell you that the NHS is their number one priority. The NHS has achieved the same status as the Queen Mother did in the nation's affections. But I do not see an appetite to change it fundamentally, and as a consequence, I think over time it will become a much hotter political potato than it may be at the moment. As expectations increase, performance will inevitably lag behind. The challenge facing all politicians will be to how to square this unsquareable circle. And the truth is that they will abdicate this responsibility to health professionals and then blame them if it all goes wrong. In future, most government initiatives are likely to be centred around preventative measures rather than structural ones. Preventative healthcare has grown in visibility in recent times. An anti-obesity drive is always guaranteed to provoke big headlines in mid-market newspapers, as well as intense discussion on radio phone-ins. Such initiatives give the appearance of action, even if they can be incredibly expensive in PR costs. Politicians love them. They're great for photo opportunities, sound bites and gimmickry. So expect a lot more of the Health Minister Anna Soubry exhorting us in her best nanny-like tones to eat less, drink less and exercise more. There needs to be a rational and national debate about the scope and extent of the NHS. Should it cover illness, injuries or both? Should people insure against injury? Probably at a fairly small cost as opposed to illness. But I pity the first politician to even suggest such heresy. Can we afford to maintain the cradle-to-grave scope that Beveridge established, although I doubt that he foresaw the range of treatments currently available and their cost? I also doubt that he foresaw a health service where 2,600 people earn more than the Prime Minister, and 7,800 earn more than £100,000 a year. Now, the bald truth is that until we accept that the NHS can't and never will be able to meet all the demands made on it, we can't actually have that proper, rational debate. And the pity is that no one currently on the NHS scene seems to have much idea of the questions, let alone the answers. Parliaments drift by and the issues, questions remain the same. Expensive reorganisations take place with little or no real benefit, and anyone who dares to criticise or critique the NHS gets their head bitten off by people who profess to love the NHS. So the real overwhelming question is this. This is what I'd like you to think about as you go away from this lecture today. If we were in a position to set up a health service now, from scratch, what would it look like? Because I do think one thing is for certain, it wouldn't bear much relation to what we have today. Thank you for listening.
Just want to kind of take any questions if anyone's got to say anything before.
I think I'd like to congratulate you. I don't know you, I don't listen to your programme. I've obviously been
4 to 8
listening.
p.m. weekdays, LBC.
I'm a today man, but obviously I've been missing a lot, and thank you very much for that wonderful presentation. There's so much in it, it's difficult to know what to mention. I think most of us agree with everything you said. But somewhere at the beginning, you said, I believe you said, that this can't be taken out of the political arena. Why not?
Well, I thought I'd explain that. The
Well, I wasn't quite clear.
The main reason is because any organisation, any institution that spends 115 billion or whatever it is each year has got to be publicly accountable. And I think the only way it can be accountable is to Parliament. And if you have a sort of a wise body of the great and the good, sort of as a board of the NHS, with no political input at all on it, I just don't see how that can be properly accountable. Think about primary care trusts, which were effectively a sort of local microcosm of that suggestion, where you had a PCT board which would have sort of, they had medical professionals on, and then sort of establishment people from within that local community. And nobody ever felt that they were accountable to anyone because there was no democratic input into them. And I think when you're spending those kinds of money, if it's a sixth of public expenditure, there has got to be political accountability. Somebody somewhere has got to be, they've got to be where the buck stops.
I'm just thinking you were saying we should create a health service. If we were going to create it today, we would be thinking differently to the way this health service was created. And to leave the health service in the hands of politicians, to me, is a starter problem.
Well, I don't think it should be left in the hands of politicians, but in the end, the public needs to have somebody that, if something goes wrong, in the end they can go to. And that's where I think that we have a problem now, in that the NHS is such a large institution that is it possible for actually one person to be, like the Secretary of State for Health, is it possible for that person to actually know what's going on? Now, Jeremy Hunt has his detractors in the NHS, I'm absolutely aware of that. But I found he did an interview with me a few weeks ago, and he told me off air that every single week he does a shift in a hospital somewhere around the country. He likes to do it incognito, but that's not always possible because people do recognise it. But he says that he learns more from doing that each week than he does from any briefing from a civil servant because he can see things at first hand. Now, you could argue, well, if he was a Secretary of State with a health background, he might not have to do that because he'd know the things anyway. But he's only one person, and you think of the sort of multitude of issues that will have to come across his desk each week. I don't know how he or how any Secretary of State can really do that job properly, but it's probably the same with most cabinet ministers. You look at the things that the Home Secretary has to deal with every day. And yes, they have junior ministers that they can delegate things to, but in the end, he's where the buck stops. And I think the public, well, they probably don't recognise the enormity of the job, but they can actually identify him as the person who is responsible. How many of the public know who the chief executive of the NHS in England is? I'm not sure I would have done had the mid-staffs thing not happened. So you can have civil servants advising and doing a lot of the legwork, but I don't see officials being able to be accountable in the same way that politicians are, or should be.
So, thanks very much. I guess, it could have been Mr. Ferrari or even Cormac Clegg, and then we'd feel even more battered.
Well, the intention wasn't to batter.
No. So when I interview 17-year-olds for places in medical school, I sometimes ask that question: how would you organise a national health service if it wasn't for the NHS? And what I find interesting is most 17-year-olds end up telling me that they think the NHS is the best thing since sliced bread. So I think one of the issues that we have is we recruit people already with the mindset, because they've grown up, they've been children, they've been looked after within the NHS structure. They then spend all their professional lives within the NHS structures. And I think then it is very difficult if you are a professional that have been recruited with almost NHS values, have been trained in an NHS system, to actually start thinking outside the box.
A cheeky thought. I think people who were in the Russian Communist Party would have said the same thing. They were recruited into it, but eventually they saw that there were alternatives. I mean, Angela Merkel is a good example of that, I suppose. It was a flippant example. But I think that people ought to be encouraged to think outside the box. But the question is, if lots of people do that and come up with radical suggestions, where do those suggestions go? I mean, who do they make them to? Because I imagine, and I've never, well actually I have worked in a hospital when I was in my gap year in Germany, but not in a British hospital. I imagine that there is a certain sort of, no, that would be too risky, we can't possibly look at doing something like that. Even if the person they're talking to, something sort of is triggered in their brain, but they think, well, no, I'm going to be held accountable for that if it all goes wrong. And I think that happens in all large organisations, whether they're private sector or public sector. So it's a really, really good point.
I'm not too negative here, but I think what Jeremy Hunt doesn't see when he goes and does a shift is the history of the stepwise deterioration in staffing, both nursing and medical, that has occurred over the last at least 30 years. Many of those years I have seen.
But why is that?
Well, you've actually mentioned most of them, actually. Yeah. And maybe you haven't realised. but I remember in the 80s, the day it happened when the nurses went on to what was called the nursing process from Project. No, before Project 2000, the nursing process, when suddenly nurses were not aware of patients on the ward. It was almost overnight, and the nursing process, the Project 2000 just compounded that when they all had to have degrees.
Yeah.
And then the doctors got in on the act where they changed training. So you didn't have to be, you didn't have to work from what was the obvious apprenticeship, surgery, medicine, whatever it was, just went because you couldn't work the hours, you weren't allowed to work the hours, you weren't allowed to be around. And there have been certain steps along that way which I think have compounded the whole thing. And I think if you want to put it right, those steps have to be sequentially reversed. You mentioned the GPs, same thing. It all has to be reversed. It can't be done overnight, and there are obviously other factors in terms of funding, things like technology, drugs, and so forth. But when it comes to people, it was people who used to run the NHS, people who were first on the line, and well, many of us here who remember those days, when we were on the ward and all working to a common cause. And I think it won't happen, obviously, but there has to be a stepwise change in the
You see, I think that's what Jeremy Hunt was actually trying to say when he talked about the sort of depersonalisation that's occurred. I gave a few examples of where I think that has happened. And the thing is, I talked a lot about anecdotal evidence. That experience that I had when my mother was in hospital, that's been my major experience of the NHS in the last 20 years. The biggest one anyway. Now that clearly, as you heard, was a negative experience. Now I have talked about it on the radio, and of course that then encourages lots of other people to bring in, so yes, that happened to me as well. Not forgetting, of course, that there are lots of other people who have had a very positive experience. Anecdotal evidence is what most people use. I mean, not just in the NHS, but in all walks of life. If you've had a good experience, you will be the NHS's best marketeer. You will go and tell people how brilliant it is, which is why, as I said, I'm very careful when I'm doing a phone-in to try and solicit sort of all sorts of experiences, because the easiest thing for a radio host is to say, tell us your complaints. And of course then all you get is one side of the story, and people who are listening end up thinking that all is doom and gloom and that every single hospital is about to kill them. And broadcasters have a responsibility, but they also have a responsibility to hold institutions to account, and that's what I like to think we do, but in a way which is not sensationalist. If I want to be sensationalist, I know exactly how I can do it. And I'll be completely honest, but there are one or two of my colleagues in this industry who delight in doing that, and they make their reputations on it. Well, I think that's the wrong thing to do. I've got no interest in being a shock jock, because it's the easiest form of broadcasting. What I get huge amounts of pleasure from is when I do a phone-in on a mental health subject, and the phone lines light up, because when I first did them, I thought, who on earth is going to phone in and tell people on the radio that they've got a problem with their mental health? It's just not going to happen. But it does. If you as the host come across as somebody who's not going to condemn them, is actually going to understand, is going to actually provide a bit of empathy, and maybe will actually encourage other people who are listening to think, well, so I'm not alone then. And as I said, that I know from other calls that I get is exactly what happens, where people think, well, I don't know anybody else who suffers from this, but they hear the experience on the radio, and then they think, oh, there is someone out there that I can actually go and talk to. And it makes for great radio, actually, when you have these sometimes very emotional stories. And as you will have seen that, I can cry at the drop of a hat, and some of these stories are so emotional that they do make you, as the host, very emotional. But I think they provide almost a sort of bit of a therapy for some people that are listening. Unfortunately, I used to do those in the evening. When you're doing the drive time show, you're a bit more constrained in what you do, because you have to follow the news agenda a bit. But I still get more pleasure out of doing those sorts of phone-ins than I do about sort of immigration or something.
We'll just take one more comment. I would you want to say something.
Thank you very much for your presentation. It was very moving. I think after a long time there has been some serious thoughts of restructuring, and as a start we now know that dementia, mental health and neurosciences, they are now sitting in the same network. But the challenges are extreme, because as a member of the CRG in neurosciences, I know that the level of service that you need to design and deliver, and the constraints of finances and the structural disparity make it an impossible challenge. I think you have touched on most aspects of the healthcare, and I'm very grateful for the openness with which you have described your own experience. I just wanted to add a small thing, and that is, even doctors, or as doctors who work in the NHS, we feel frustrated that we can't do enough for our own patients. Yeah. And that's a real frustration, because we want to do a lot more.
Understood.
I don't know where the nurses in the room are, and I'm standing up. As one of those working class nurses who now earns more than the Prime Minister, I think I just need to say something. I think it's very easy to, and I totally agree with most of what you said, to be honest, but I think it's very easy to put our past in rose-tinted spectacles. I actually got into management because of the horrific care and the things that I saw in the 70s and the 80s. The difference then was it was all brushed under the carpet. People like you didn't talk about it on the radio. The CQC didn't exist.
And the internet didn't exist.
And the internet didn't exist. And it was all brushed under the carpet. Nurses need to have